Well, welcome. My name is Scott Suko. I'm the executive director with the Liver Coalition of San Diego, and this is our Hepatitis C Elimination Learning Exchange. And it's exciting today because the topic is really a case study determining prevalence, the role of surveillance, and modeling to inform stakeholders. The Elimination Hepatitis C for San Diego County, our initiative, is a public-private partnership to eliminate hepatitis C by 2030. Our process started back in November of 2018 and went through the County Board of Supervisors with multiple approvals on their part, first with our plan of work and then with our implementation plan. It involved 12 months of community stakeholder input to get to that point. And then ultimately it was approved by the Board of Supervisors in December of 2019. The Liver Coalition of San Diego in January 1st became contracted with the County of San Diego to serve as the convener of the partnership. And we've enjoyed that role, and that's why we're here today. Moderating today's discussion is ANDREA TOMADA, who's with the County of San Diego and has really been a valuable partner, not only as our vice chair of our elimination efforts, but also within the County of San Diego with the division that she works in. She will lead us through today's discussion and introduce our speakers. So at this point, I introduce ANDREA.
Thank you. And just a couple of housekeeping items. I just wanted to remind everyone to please make sure you remain muted while our presenters are presenting. And I believe at the end, we will be doing a question and answer session. Also, if you'd like, you can put your questions in the chat, and I believe Brian Clary will be reviewing your questions in the chat. So at this time, I'd like to go ahead and introduce Dr. Natasha Martin, who will be presenting the disease burden and what intervention scale up is needed to achieve HCV elimination here in San Diego County in modeling analysis. Dr. Martin comes from the Division of Infectious Disease and Global Health of University of San Diego. So I'll go ahead and pass it over to you, Dr. Martin. Thank you.
Great. Thank you, Dr. Tamada. It's really nice to join everyone today. As mentioned, I work at UC San Diego, and part of my work is developing analytics to help us understand where we are with our infections today and what do we need in order to scale up and reach our elimination targets in the future. So just as a point of clarification, I was originally thinking that we would present the burden estimation and then there'd be some discussion from Sam about epi surveillance and then come back to the modeling. Is that still right? Or should I just present the burden estimation and the modeling together? What would you like, Dr. Tamada?
You can go ahead and we can go with the plan. So if you'd like to do the burden, then we'll go with Dr. TWEETEN. That'd be great.
Great, sounds good. Okay, so essentially I just have one slide to show you today in the very beginning, and then we'll go back to more of the work that we've done in this area. But just by way of a bit of context, San Diego County has developed in partnership, a public-private partnership to eliminate hepatitis C locally. And the elimination plan has two main goals. And those two goals are to reduce the incidence or the number of new infections of hepatitis C by 80% by 2030, using 2015 as a baseline, and to also reduce the number of hepatitis C related deaths by 65% by 2030 compared to that 2015 baseline. So with that in mind, we have these goals of reducing new infections and deaths, and we have a timeline, right? So the start is 2015. We have this target date of 2030 by which we're going to expect to see reductions in these hepatitis C related outcomes. But one of the things that we didn't know when we were starting with this exercise is, well, where are we right now? What is our baseline? And so my group it's pooled a number of different data sources to try to understand where we are at the start of our elimination plan with regards to hepatitis C burden in San Diego County. So I will share that slide with you right now. Hopefully you can give me a moment. And what we did here is we pooled available data in terms of the populations who are at risk for hepatitis C infection. This is primarily, as you can see here on the left, I'm sorry for the acronyms, people who inject drugs or PWID, men who have sex with men or MSM. Of course, we have individuals infected in the general population, both men and women of various ages. And there are also hepatitis C infected individuals who are incarcerated in California state prisons, but who are San Diego County residents. So we tried to start with that understanding of the number of people who are in these various groups. And then based on our best available epidemiological data in terms of the proportion of those populations who have history of exposure, or what we call hepatitis C seropositive, we were able to estimate how many individuals residing in San Diego County have a history of hepatitis C infection in 2018 when we did this work. So this, again, was motivated to try to give us a baseline understanding of where we are at the start of this program in terms of hepatitis C countywide. And what we found is, if we start at the bottom here, was that our analysis estimated that just over 55,000 people had a history of hepatitis C in San Diego County in 2018. And most importantly, what's emphasized here in the red is that by far the a large proportion of those individuals, or about 17,000 of those individuals, are people who inject drugs. And so what that tells us is that we know kind of how many people we're starting with, about 55,000, but a very large proportion, sizable portion of those are people who inject drugs. And so it helps us understand that those individuals, in addition to the other individuals I previously mentioned, are really key populations and priority populations for our elimination efforts moving forward in the future. So with that, I'll hand it back over to you, Dr. TOMADA and Dr. TWEETEN, to kind of discuss the context in terms of where we are with surveillance.
Thank you, Dr. Martin. So I'd like to go ahead and introduce Dr. Samantha TWEETEN. She's our senior epidemiologist here at the Health and Human Services County of San Diego, and she will be going over the epidemiology here in the county. Oh, I don't think we can hear you. You're,
How about now?
we can hear you. Great.
I accidentally pressed my separate mute button. Thank you very much. I'm going to go ahead and do some slide sharing, which hopefully will work well. Okay, it is my hope that at this point you can actually see my slides.
We can see.
Okay, great. So, as Andrea said, I'm going to be talking about surveillance as it is in San Diego County through the County of San Diego Public Health Services surveillance. I am the HIV and hepatitis C surveillance coordinator for the County of San Diego. And there we go. So I want to just start with talking about what surveillance is from a public health standpoint. This is not surveillance from the FBI standpoint at all. It is strictly from the public health standpoint. And it's defined as the ongoing systematic, keyword, collection, analysis, and interpretation of health-related data essential to planning, implementation, and evaluation of public health practice, closely integrated with the timely dissemination of these data to those responsible for prevention and control. Big, big definition. But basically, it comes down to getting information in a systematic and appropriate way with the goal of providing information back that can be used for public health action by public health personnel, government leaders, community-based organizations, and the public. And that public health action can be direct prevention of disease transmission, but in this case, at this point, it's largely a matter of guiding public health policy and programs. So that's what it is. Let's talk about California a little bit. In California, we have Title 17 of California Code of Regulations, Section 2500. These are reportable diseases and conditions as it pertains to healthcare providers. And in the epi world, in public health, we generally just refer to this as Title 17, and everybody knows what we're talking about. It covers the reporting to the local health authority, most frequently the public health officer for any given jurisdiction, by healthcare providers. This is kind of a tricky one, and I say that because, in all honesty, it frequently doesn't happen. But it's not that we don't get reports, we just don't necessarily get them from healthcare providers. But I do want you to know what is in the Code of Regulations. Essentially, it says that it is the duty of every healthcare provider, knowing of or in attendance on a case or suspected case of a given disease, to report to the local health officer for the jurisdiction where the patient resides. So actually, if you're treating somebody in San Francisco and they live in San Diego, you're supposed to report it to San Diego. This also covers administrators of any facility, so facility, clinic, variety of settings, that you have to set up and be responsible for administrative procedures to make sure that these reports are made. Ooh, not mad, but made to the local health officer. The section is very clear about what a healthcare provider is, and it covers a lot of things: physician, surgeon, a veterinarian, podiatrist, nurse practitioner, physician's assistant, any registered nurse, a nurse midwife, school nurse, an infection control practitioner, whether they are a licensed healthcare provider or not, medical examiner, coroner, or dentist. So broad scale of people. Now for hepatitis C specifically, it means, and it states, that a case or suspected case has to be reported within 7 calendar days. And anything in section 2500 that says 7 calendar days can come in by fax, telephone, or mail. As I said, it doesn't happen very often because we have electronic lab reporting here. And so this is covered by Title 17, Section 2505, which covers laboratory reporting to the local health authority. So labs have to report test results, not just molecular, but also pathologic results that are suggestive of disease. They have to report both initial and subsequent findings, and they have to report negative results when the California Department of Public Health or the local health officer requests it. And this has been happening with hepatitis C. The CDPH, California Department of Public Health, has requested labs to report negative viral loads. For laboratories, Hep C reporting has to be done within 1 working day. So we've got what surveillance is, we've got what do the regs say about it. So what do we see in San Diego? These are our values, our numbers for 2023. And in that year, last year, we got almost 5,400 case reports. The vast majority, and by vast majority, I mean of those 5,400, we probably got 3 or 4 reported by healthcare providers. The rest came in by labs. So we got 5,400 that year. We were able to immediately close almost 3,100 as not a case because they came in with a positive antibody test, but a negative viral load. So they had some exposure to it, but they did not have any active virus in their system. We had almost 1,400 probable cases. These are the ones that have just an antibody test, and we have not yet received a viral load. There is a piece of law in California that says that providers do have to either order a reflex test, positive antibody to a viral load test, or they have to subsequently order that viral load test. But as you can see, we had 1,400 who had an antibody test that was positive, but we didn't get any viral load results. 89 of them were not residents of San Diego County. we take those and we refer them to their jurisdiction of residence. So this is very similar to we're treating somebody here who actually lives in San Francisco. We let San Francisco know about these cases. We confirmed 822. These are people who had a detectable viral load, and these were all investigated. We did receive, finally, because we're finally getting them, well over 15,000 negative results. These are negative antibody and or viral load results. We do match those negative viral loads to existing cases, and that is helping us determine the level of viral clearance for those who did have active disease. We also had acute hepatitis C cases. We identify those by looking at the ones that come in as chronic. And we managed to confirm 127 of those. 15 were non-resident, and the vast majority of those were donor-derived. We did have 34 donor-derived acute cases. These are people known not to have hepatitis C, but who received a known hepatitis C positive organ. The state's actually very happy with us for reporting these. Okay, in terms of our investigation here in San Diego County, we do count all probable and confirmed chronic cases. For any confirmed chronic, these are investigated by medical record review. That really works well only when we get complete medical records. The probable chronic, unless they are members of special populations, are not investigated because we do not have the staffing capacity to do it. We would very much like to be able to actually do follow-up to encourage subsequent viral load testing on all of these, but we don't have the staffing. We do investigate by medical record review anyone who is under the age of 30, pregnant, or who is co-infected with HIV. So we do have some special populations that we do look at. Anything that's a confirmed acute is investigated by both medical record review and interview. There are two exceptions to that. The donor-derived cases, because we know what their risk was, and because we know their donor cases, we have access to their medical records so we can get their demographics. And we do not interview incarcerated cases. Incarceration at this point, we're talking about people who are, for our purposes, in federal, state, or county correctional facilities. It is unwanted for us to go in and interview or even call to interview the confirmed acute who are incarcerated. We make every effort to get the medical care staff in the facility to gather the information that we would like to have, though. It's mixed success on that end of things. So why do this surveillance in the first place? There are basically four really big reasons. And the first is to understand the burden of disease in the county. And as we firm up and mature our surveillance system, it will get better and better at doing that. And that, in conjunction with the modeling that Dr. Martin's going to talk about, can give us really good estimates of the burden in the county. The second is to understand the populations who are most impacted by this. If you understand the populations most impacted, it means that you can provide that information to groups who develop interventions, who develop programs, who develop care models. So it provides information to develop both prevention and care components. And last, but certainly not least, it hopefully, as it matures, will give us a pretty good way to monitor the progress of our elimination initiative efforts. So I'm going to go over pretty quickly some of the data we have been collecting over the last year. In this slide, basically, we simply have the total number of reports, regardless of their resolution status, and based on their resolution status. We have most were received and went in as chronic. You'll notice we've got a huge gray bar. Those are our NATA cases. The non-residents I talked about, I'm talking about the graphic on the right. And we also are charged with investigating perinatal hepatitis C. Perinatal basically is vertical transmission, mom to baby. But regardless of whether or not we know it was mom to baby, once they are over the age of 3, they are no longer counted in the perinatal category. If at their time of diagnosis they are over the age of 3, they are not considered a perinatal case. We are working with the state to try to have better understanding on why that is. So, as you can see, vast majority of our cases so far are in fact chronic. If we look at the gender of our chronic cases, we do have about a 3-to-1 ratio of males to females. We have not gotten a lot of information on trans women or those who are assigned male at birth, but whose gender identity is female, or those who are genderqueer, non-binary, or other categorization, self-categorization. This is probably, well, I am pretty certain this is underreported, but this is the information we've gotten so far. In age category, we do see a nice, fairly typical uptick up in age, and then a drop down at those over 70. One of the things that does happen here is that people who have chronic disease may not be diagnosed until they are very far advanced in their disease. And one of the pieces of speculation that we are looking into currently is what's actually happening in those moving into the 70 and above. Is this a true drop, or is this a matter of there are not people surviving to that point? Again, lots of things we're looking into. If we look at race, unfortunately, we still have a whole lot of unknowns. These are largely reported by labs. Labs are not required to provide race ethnicity information. If we cannot get subsequent medical records, we don't have that information. The unknowns notwithstanding, at this point, what we see in chronic is a substantial proportion who are white. In hepatitis C, unlike HIV, ethnicity, Hispanic or Latino, or not Hispanic or Latino, is separated out. So we are able to look at those separately. Again, we have a very large unknown because if it's only coming in on a lab, we don't have it. We have more non-Hispanics in our chronic set than we do Hispanic. Remember, we have 822 confirmed. Big question frequently is how much injection drug use happens. And of those for whom we can get the information, it is a substantial portion, 225 to 82, but very large numbers of unknown. If we look at gender of acute cases, we're going to switch over to our acute cases. We do see a little bit of difference. The first thing we see is a much larger ratio of male to female. And we do have more, although it's not a lot, but as a proportion, it's a lot more of trans women. We have 127 confirmed acute cases, just to keep the numbers in balance. If we look at the age groups, for the acute, it does tend to peak. And this is actually fairly, it goes along with other jurisdictions, and specifically in California. and in other parts of the country, where we do see a peak, generally in the 40s. In some areas, it's a little lower in that 35 to 39, but usually it's in the middle. A number of for the acute cases, a number of those who are over 60, those are donor-derived cases. Most of our transplant-related cases are in older people. If we look at the race and ethnicity of our acute cases, again, we do have a substantial number where race is unknown, but race white is still the largest that we see. Interestingly, Hispanic Latino ethnicity is larger than our others, but we don't know how many of those unknown where they're going to fall out. But of those where we got the information, unlike in our chronic cases where there are more non-Hispanic Latino, in this case, we have more Hispanic or Latino. The injection drug use in the acute cases, we have about the same proportion of unknowns, but the proportion of those people who inject drugs is smaller compared to those who don't when compared to our chronic cases. Still the big hitter, though. Still the big hitter. And that is where I'm going to stop in the very basics of our surveillance. My contact information, if you have any further questions. And I will turn it back to ANDREA.
Thank you, Dr. Tweeten. All right, and I will actually pass it on to Dr. Martin to now go ahead and present on the presentation of the intervention scale up.
Andrea, do you mind if I just interject something quick as Dr. Tweeten was talking? I remember in our planning process, we, our public health officer, Dr. Wooten, would say, how will we know when we're successful and where to allocate resources? And when we started, we didn't have all that information that Dr. Martin is about to present. And, you know, Dr. Tweeten and her department has been ramping up as well. They were doing great work, but they continued to make some investments. So when we did our implementation plan, we didn't rank what we were working on by what we're going to learn today. We ranked by ease of implementation. So we had phase 1, phase 2, and phase 3 for all of our strategies and tactics. And that was based on how easy, there's no money involved. It's an easy thing to do. Second is maybe we could reallocate some resources or procedurally make some changes. And 3, there needs to be resources allocated. So this next iteration that the initiative is about to go into will be based off of what Dr. Martin is going to present. So it's a kind of exciting time to evolve as many communities across the state and country are doing as we work with what we have until we can get the answers where the county and those that allocate resources feel confident that they can put system resources behind the next direction. So it's exciting to hear Dr. Martin's presentation. And thank you, Andrea, for allowing me to interject that.
Absolutely. Thank you, Scott.
Yeah, thanks you both for that framing. I think this is a really great session because essentially what we're trying to do here is trying to take the first steps to understand, you know, what is the burden of hepatitis C in San Diego County? What is the epidemiology of it? What are the groups that are most effective? And then where my group really steps in is saying, okay, what kind of data and analytics do we need in order to understand how to reach these elimination targets? What level of intervention do we need? Are we on track to reach elimination? Do we need scale up? And then try to ask these harder questions that Scott mentioned about, well, you know, what different kind of combinations of interventions can help us achieve these goals? Thinking forward, and then of course, what are the data that we need to track and monitor our progress as we go to ensure that we are meeting these elimination targets? So my group's role here, we've done quite a bit of work recently, thinking about what level of intervention scale up do we need in order to reach hepatitis C elimination in San Diego County? And we do this by developing simulation models. And for those of you that are not familiar with simulation modeling, I'll take you through a little bit in a second. But first, I want to talk about reaching hepatitis C elimination. I mentioned that there are two elimination goals. One is to reduce hepatitis C incidence, or the number of new hepatitis C infections, and the other is to reduce hepatitis C related mortality. And the difficulty with that is true hepatitis C incidence is very difficult to measure directly. As you've heard already, many individuals are diagnosed late. They can go for decades with undiagnosed asymptomatic infection. And so therefore, we could potentially be seeing these infections later on, and we're picking them up very late. And so trying to understand how many new infections are there in San Diego County every year, and how is that going between now and 2030 is very difficult to measure directly. So models that simulate hepatitis C incidence and transmission can help us both estimate what is the current incidence, how many new infections are there likely today, what is our predicted future incidence given what we're doing, are we on track to reach hepatitis C elimination, and if not, what level of intervention scale up do we need in order to reach these targets? Now, what is simulation modeling? I know it feels like a black box, and there's a lot of different types of models. People use the word models to mean a lot of different things, but essentially at its essence, what it is it's a very simplified representation of what is a complex phenomenon. But what we try to do is we try to create logical rules or equations which attempt to mimic the real world to help us understand these, gain insight into some of these questions that I mentioned about how many new infections do we have and what do we expect in the future. Now, why do we need this kind of simulation engine? Can't we just look at the number of new diagnoses over time and look forward in the future? Well, there's two critical issues with that. One is, as I mentioned, many individuals are diagnosed late, and many acute infections are not diagnosed immediately. And so we don't have a really good picture from the direct epidemiological data, surveillance data on new infections. But additionally, even if we did have an understanding of how many new infections there are today, incidence in new infections can change over time. So for example, if we were in person and I came today and I was infected with some kind of respiratory virus, spread it to somebody here, then one person might come back infected tomorrow and we have one new infection. But let's say we regroup together tomorrow as a group in person. We have two people now infected. I'm infected, somebody else is. And we each infect one other person. Well, then there would be two new infections tomorrow. And let's say we get together a third day and we each infect other people, then maybe there are 6 new infections the next day. And you can see that the number of new infections is changing over time. And in this example, kind of following what is a traditional sort of exponential curve that we often see in outbreaks of these sort of increasing number of new infections over time. And that can happen naturally as an infection spreads through a susceptible population. But the number of new infections can also change over time due to demographic change. Let's say people see that there are, I'm infected, and so you don't come back in person. You decide to sign on in Zoom next time that we meet. That behavioral changes can change these things. Prevention interventions. If I show up with a mask tomorrow, then that might affect the number of new infections. So we have a lot of different things that can alter the trajectory of new infections going forward in the future. And we really need a kind of simulation model that incorporates both mechanisms of transmission as well as prevention and, let's say, treatment interventions to understand and predict into the future. So that's why we build these simulation models. And so what we did for this particular project is we wanted to build a simulation model that was able to look at hepatitis C new infections or incidence and mortality. And we built it based on a previously developed model that we had, and it simulates hepatitis C transmission and disease progression for adults in San Diego County. So it has that mechanism of transmission, also has the mechanism by which individuals progress through disease stages and maybe get end-stage liver disease, some of them, and maybe die of their hepatitis C if they're not treated. It also incorporates hepatitis C treatment, as well as harm reduction interventions that are highly effective at preventing transmission among people who inject drugs. And we have this simulation engine, and we base it on epidemiological data from San Diego. So as much as possible, we use local data to inform our modeling to ensure that our models are kind of realistically recreating the epidemic that we've observed here in our county. And again, the value of this thing that we build, this simulation model, is that it can predict into the future, because that is what we want to know. Now, there's a lot of data inputs that go into these models, and I don't have the time to go into them, nor do I think that you're interested in all of the details, but I will bring up one very key assumption and piece of data that we use to inform this model. So we use the burden estimation, which I previously just presented in terms of the number of people with hepatitis C in San Diego, but we also needed to have an understanding of how many people are being treated and potentially cured for hepatitis C in San Diego County right now. And what we found is we did some other analyses among cohorts of people with hepatitis C, and we found that with Ryan White funding, which has provided very stable and comprehensive funding for people living with HIV, for people that are living with HIV, about 55 to 60% of people with HIV that also have active hepatitis C infection are treated for their hepatitis C every year. So that's a relatively high treatment rate. Of course, these individuals are engaged with care, they're attending care for their HIV, and then, subsequently have the opportunity to be diagnosed and treated for the hepatitis C within this Ryan White funding framework. Now, unfortunately, the picture is quite different when we look at other populations in particular who do not have HIV co-infection. And there, historically, we have not seen substantial funding. And without that substantial investment, we see that among specific populations, such as people who inject drugs, there have been likely little to no historical treatment in that group. Now, we really lack robust data in monitoring this group, but there are local cohort studies that track people who inject drugs and follow them. And what we see is despite some, local efforts, for example, among family health centers, and we know that there are providers that are trying to get out in the community and treat people who inject drugs, overall, unfortunately, the existing data that we have indicates that there has been very little treatment in this group. Now, why this matters is because people who inject drugs are the main group at risk of ongoing transmission for hepatitis C. So if we're not able to treat this group and cure them of their hepatitis C, they remain at risk of transmitting to others. So what implications does that have for the modeling? Well, I'll show you a few of our key model outputs today. First, these are our model projections of the hepatitis C incidence from 2015 on the left-hand side of the slide to all the way out to 2030. So these are simulated projections. And the y-axis here is the number of new hepatitis C infections. The black line is our sort of mean model production. The gray shows uncertainty. There are uncertainties in our projections, but what you can see here is that broadly speaking, we're estimating that there are between 1 and 3,000 new hepatitis C infections every year in San Diego County. And if you look overall, you can see this trajectory is not declining. And so with what we're doing right now, our simulation models indicate that there will be no incidence reductions without enhanced programmatic efforts to prevent and treat hepatitis C. So this is indicating, unfortunately, that we're not on track to reach our incidence target without doing more. But there's good news. And the good news is that what we can see with our modeling is that we can reach the target. So here, I'm still showing you the number of new hepatitis C infections over time. Here, the dotted line is our continue with the status quo, continue with what we're doing today. And now here, our black line is, well, what happens if we scale up treatment, in particular to our populations most at risk of transmission, so people who inject drugs and men who have sex with men. And what we see here is that if we scale up treatment in these priority populations from negligible that we estimate now to just under 60% per year, we could reach this elimination goal of reducing the number of new infections by 80%. Now, the reason why that 58% number is really I find kind of optimistic is if you think back to what I was telling you about what was achieved with Ryan White funding, we are able to reach these treatment rates among people living with HIV in San Diego County today. We know in that population with committed funding, people with HIV are treated at this rate. So it helps us understand that with committed funding, we may be able to achieve this level of treatment in our other priority populations, and we may be able to reach treatment elimination overall as a county. However, having said that, it's still a very high treatment rate. Treating 68% per year requires, a lot of scale up in terms of both diagnosis to ensure these populations are diagnosed as well as treated. And many people, especially people who inject drugs, are not in regular contact with the healthcare system or may not be tested and identified earlier for their hepatitis C in order to treat them. And so finally, one of the other things we looked at is, well, what if we have a combination approach? What if we improve access to treatment and we also scale up harm reduction for people who inject drugs? Now, harm reduction interventions are very highly effective interventions that prevent the risk of hepatitis C transmission. They can prevent HIV transmission and also fatal overdose. So here I'm talking about harm reduction interventions such as opiate agonist treatment, or also called medications for opioid use disorder. That's buprenorphine and methadone, for example. Those medications are very effective, as I mentioned, reducing HIV transmission, hepatitis C transmission, fatal overdose. Additionally, syringe service programs are also highly effective at preventing hepatitis C by preventing sharing of unsterile syringes and paraphernalia. So here what I'm showing you on this slide is the impact of if we scale up harm reduction interventions and which achieve reductions in injection drug use related risk for hepatitis C. And so this blue line here is what I showed you in the last slide. This is just under 60% treatment rate that we would need without any harm reduction scale up in order to reach that incidence elimination target. But what you can see here with these lower bars, the orange bars and then the gray bar, is if we scale up harm reduction in order to achieve here, the orange bar is 25% injecting risk reduction, and this gray bar is a 50% injecting risk reduction. If we do that at the same time as expanding treatment, then it reduces the number of people we need to treat. And that's great for a few reasons. Number one, it makes elimination more achievable because we can achieve elimination with fewer treatments. It's also, in other analyses that we've done, more cost-effective because hepatitis C treatment is very expensive, and comparatively, these harm reduction interventions are very cheap. And as I mentioned, there's additional benefits. So as we provide this comprehensive harm reduction and treatment approach, we both prevent people from getting hepatitis C. Among individuals who are treated with hepatitis C, they have a reduced risk of reinfection if they're also provided harm reduction interventions in combination. And we have these secondary benefits on preventing HIV and fatal overdose among this really marginalized population. So this really emphasizes this idea of, this comprehensive approach as being the strategy that will likely be most effective in enabling us to reach elimination in the future. So finally, just to kind of recap, the simulation models that we've generated have shown that at the moment, we're not on track to reach the hepatitis C elimination goal, incidence elimination goal in San Diego County, but it can be achieved, especially if we provide a comprehensive combination prevention and treatment package, which will involve enhanced diagnosis and treatment, particularly among people who inject drugs, with 2 levels which have been achieved among people with HIV. It will be even easier if we can expand it with harm reduction services, syringe service programs, medications for opioid use disorder, which in combination can reduce hepatitis C risk by 80% together. So again, these are highly effective, and if we scale up these services in combination, they have a lot of synergistic benefits for our population, really enabling us to achieve this hepatitis C elimination program. And as I mentioned, I hope this work in general provides us with a framework of, how we might get there. And then all of the work that you've seen here today, both surveillance and modeling, can be used to track our progress as we go, make adjustments as we go, and monitor whether or not we're able to achieve elimination by that 2030 target. So thanks very much.
Thank you so much, Dr. Martin. That was great. Does anybody have any questions about the presentation that Dr. Tweeten or Dr. Martin has presented today? I'd like to open the floor for that. Okay, is it what was Wasson? I think you're still on mute.
Oh, okay.
There you go.
Hello. Okay, yeah. Yeah, this is Wasan from Orange County. I'm very interested to know more about the modeling that you did and what kind of data you provided so that you generated those and based on which statistical modeling. Yeah, that just the way that was generated. I'm interested to know more.
Great question. So I'm also happy. I'll put the original publication in the chat. As I mentioned, this was work that was built on top of a simulation model. This is what we call a compartmental deterministic model. So it disaggregates the population into different compartments and uses differential equations to simulate transmission. And the data that we used was from multiple sources. So we had size estimates for our different populations who are at risk. We used our burden estimate that I mentioned, which was also, I'll put that publication in the chat as well, which used a combination of cross-sectional surveys of seroprevalence among different populations, as well as blood donor data in order to inform those estimates. So we had cross-sectional surveys among people who inject drugs, men of sex with men, and blood donor data, as well as some surveillance in prisons that we were able to use for that burden estimation. In terms of the simulation model, other sort of data sets that we used, we had literature, we used data from published literature in terms of the natural history of disease progression. But in terms of other local epidemiological data, one of the main pieces of data that we relied on was cohort data, as I mentioned, among a longitudinal cohort of people who inject drugs here in San Diego County. That's a cohort that's led by Stephanie Strathty at UC San Diego. It's actually a binational cohort, so they follow people who inject drugs in San Diego as well as in Tijuana. They're very interested in sort of cross-border infectious disease transmission, HIV, hepatitis C, and overdose. That cohort of people who inject drugs does baseline surveillance for hepatitis C, as well as ongoing surveillance for looking at hepatitis C seroconversion. And they also did RNA testing among the seropositives. So that helps us understand both what is the burden of infection currently among people who inject drugs, what is the incidence among new infections among people who inject drugs, and also that critical understanding that it did not look based on their RNA positivity rates among their antibody positives that there was any evidence of treatment because their RNA chronicity among antibody positives was similar to what we might expect, just assuming a spontaneous clearance rate as so sort of spontaneous clearance being the difference between those who were seropositive and RNA positive. That also triangulated with self-reported data in that cohort of very, very little to no exposure to hepatitis C treatment. I mentioned, sorry, the last thing is just that we did also have some cohort data. So at UCSD, our Owen clinic, we were able to look at treatment uptake and outcomes among HIV infected individuals in that group as well that we used for the data set. But I'm happy to share the original publication. We are in the process of writing up and submitting the publication for the results that I've just shown you today. But as I mentioned, I can send you the other publications that we have out here to give you a better sense of the data that we've used to inform the models.
Thank you so much. Very helpful. Thank you.
Thank you. Daniel, would you like to go next?
Sure, thanks. Thanks to both of you for the really great and rich presentations. I was reminded in the modeling, but also in the surveillance data of a new report. I think this is from Stephanie Strathty's cohort that you just mentioned, showing a significant shift from injecting to smoking for opioids and methamphetamine. And I think there's a general sense that ideally the risk of hepatitis C transmission is lower with smoking, and yet also that there's particular strategies or prevention needs to minimize that risk. And I just wondered if you had any sense of whether that seemed to be showing up in the surveillance data, or that's something that could be factored into future iterations of the model.
Thank you so much for that excellent question. So you are absolutely right. In that cohort of people who inject drugs, there's a recent publication indicating that there has been a sizable shift from injecting to smoking. Additionally, there's also among people who inject drugs, there's been an increase in use of fentanyl over time. And so although I agree with you, we still need to see, I think there still needs to be a little bit more data to look at whether there's any residual hepatitis C risk among people who have shifted from injecting to smoking. We might expect that that would dramatically reduce the risk of hepatitis C transmission. Unfortunately, potentially outweighing that reduction in risk, what we do also see, and I'm happy to share this preprint, which I will get in a moment, among people who inject drugs in that cohort, the risk of hepatitis C seroconversion increases with fentanyl use. So we see this changing pattern, this increase of fentanyl use among people who inject drugs appears to be associated with increased hepatitis C risk. So therefore could increase the risk among that cohort as well. So these changing kind of use patterns and risks and drug markets are really important. We are, you've seen sort of version one of this work. We're in the process at this very moment of trying to understand these shifts in injection and smoking, increases smoking fentanyl among injectors and hepatitis C risk, and putting that into models as well. That will be our sort of second version iteration. It is something we're working on, and it's still work in progress. And I think it, honestly, from what I've seen, I am still extremely concerned about this shift to increasing fentanyl use among people who inject, and the data that we have indicating that that increases the risk for hepatitis C seroconversion.
Thank you so
Thank
much.
you.
I'll go ahead and give Bill the floor.
Okay. Thank you. I pointed out to Dr. Martin a couple of more pillars in achieving elimination, which we're finding. And what I pointed out in a text to her was that we need to increase access to care in terms of just affordability, but just getting people to care and those linkages to care. And then the other one was, of course, increasing harm reduction and prevention. But that also includes the direct correlation with the opioid prevention and coalitions that are working in the community to lower the use of illicit drug use and fentanyl, and as well as the overdose and intended and unintended consequences of suicide. So we have found a direct correlation between lowering those numbers and also the incidence of hepatitis C. The next thing that we found is by increasing the capacity to deliver care, by finding ways to engage nurse practitioners and other people in the health workforce to contribute to that workload at the clinic, to then see that people are ushered through their treatment. That was another part that we found. And then we've looked very carefully at the Ryan White finding, and that's been dwindling over time. And actually to a point where in many counties, it's not sustainable. And so what has been looked at and where we are putting attention is on reforming the mechanisms of the 340B program, because that is where we're finding there's a bulk of possibilities and opportunities for funding for hepatitis hepatitis C treatment. So I just wanted to make a point of these from a point of view of what we're seeing statewide, but also we see that also impacted nationally. And I think that Daniel can definitely speak to that.
All right, well, thank you. Is there any additional comments or statements to that? And if not, I would like to just thank everybody for participating in today's meeting. And thank you again to our presenters for the wonderful and in-depth information that you provided today. And I hope everyone has a wonderful rest of your day. Thank you.
Thanks, everyone.
Thank you.
Thank you.
Thank you.